Hi, and welcome to episode 3 of season 5 of the Fat Doctor podcast. And today we're going to be talking about Jay. If you were there for last week's podcast episode, you'll know that I was umming and ahhing between Joe and Jay. Chose Jay in the end. Um, for those of you who are not familiar with this type of podcast, I have created a fictional character based on an amalgamation of patients that I have met over the last 20 years. And I've created them especially for you, my lovely listeners, uh, as a means of kind of not teaching you, teaching sounds a bit patronizing, as educating and informing you of what good quality healthcare looks like. Because sometimes it's really difficult to know what good quality healthcare looks like if you've never seen it before. It's like when you're growing up and you just think that something that you've always known is normal, and then you suddenly ask your friends or you go to your other friends' houses and you're like, oh, that's not normal, or that's not common. I should say, normal's not a great word, that's not common. Nobody else's parents do that. How comes my parents do and no one else's do? It's kind of like that, but with doctors instead. Because if you've only ever seen not so great doctors, then well, you know where I'm going with this. Anyway, I'm going to tell you all about Jay. We're going to dive in, and then I have got another segment. Oh, well, another journal article for my segment. Everything you've been told about weight loss is a lie. And I have a question for my Ask Me Anything. I'm feeling proud of myself because I'm really organized today. So, without further ado, let's get into it. Jay drives a 2008 Toyota Camry. That's apparently uh, a car that's common in America. I was going to come up with a British car, but I thought many of us would know Toyota Camrys more than we would ones that. But anyway, Jay drives a 2008 Toyota Camry. Okay, and they've named Betsy. I'm so cool. The car has over 200,000 miles on it, and while they'd love to replace it, their medical bills and the current car market value make that impossible. They've become surprisingly, I don't know, shall we say, adept at basic car maintenance out of a necessity. The kind where they leave home that 20 minutes with that 20 minutes of extra time every time they've got an appointment because you never know, Betsy might need a rest stop, a break. Not all of us can do one whole journey in one go. Some of us need to take a breather, a cool down, if you will. So yeah, Betsy's great. I mean, does the job some of the time, most of the time. Um, what can I tell you about Jay? Well, first of all, Jay injured their right knee, let's be specific, in a motorcycle accident at the age of 20. That was a long time ago. Took months of recovery. They had lots of physical therapy. They survived. No major damage. And to be honest, didn't have that many run-ins with doctors until a decade or so later when they had to go in for a routine physical because of their new job. They work in retail management. Steady job, you know. Anyway, they felt healthy at the time. This was this was quite some time ago now. They were 30 odd years old, quite healthy, felt good, no issues, maybe a bit stressful work, but nothing too serious. The nurse took their blood pressure 3 times in total. Each time they looked very concerned, increasingly concerned, the nurse looked. 145 over 95, and that's too high, folks. The doctor called it a wake-up call. Um, Handed them a leaflet all about the DASH diet. Ever heard of the DASH diet? Me neither. Well, you will. Google it. It's terrible stuff. Explaining that losing weight would bring their blood pressure down, right? Because you want to treat high blood pressure, you want to lose weight. That's the only thing that's going to make a difference. 145 over 95, you're a young lad or lass or non-binary person, I should say. Just lose some weight. Come on, fatty. Sorry, I, I went I went off for a second there. Anyway, so it's obvious, isn't it? Doctors always jump to weight loss as a solution for high blood pressure, for anything really, but especially for things like that, the kind of high blood pressure, high cholesterol, slightly raised blood sugar. Oh, weight loss will fix it. In fact, weight loss will fix anything. It's the cure-all, don't you know? And this is a very common thing to happen, not just to Jay, but to a lot of people. And so, of course, Jay doesn't want to take medication. They're only 30, so they throw themselves into a low carb diet. They get one of those tracking apps. They start walking during their lunch breaks, cut out or reduce their carbs massively, increase their protein, and over 6 months they lose an entire 45 pounds, people. And guess what? Blood pressure drops to 122 over 82. Amazing. Amazing stuff. And the doctor, of course, is pleased, makes Jay feel like they'd finally kind of cracked it. Well done, pat on the back, off you go. And so they did. Well, come back in a year's time, see how you're doing. But let's face it, the retail hours, they're long and unpredictable, and Jay's finding it harder to do meal prep. And after a while, cutting out carbs becomes a real faff. The tracking app was becoming very stressful. And even though they were trying, it's not like they suddenly just started eating carbs again the moment their blood pressure was better. No, they wouldn't do that. But even though they were trying really hard, slowly the weight crept back. 5 pounds here, a couple of pounds there. By 33, they'd regained most of the weight. And at the same time, their blood pressure was back up. Not only that, but now at 33, they have a high cholesterol. Now they're really freaking out. The doctor says, you need to get serious about your weight. Despite Jay's attempts to explain their previous weight loss efforts, the doctor's like, sort yourself out. Get serious. If the last one was a wake-up call, this is a serious wake-up call. So Jay tries Weight Watchers, not just once, several times, then eventually switches to Noom. Each program works initially. They lose, 20 pounds, 30 pounds, whatever. They do really well. And their blood pressure would go a little bit better, then get a little bit worse, cholesterol a little bit better, a little bit worse. But at the end of the day, none of these regimens or regimes were really kind of feasible in the long term. And whatever happened, they found that they'd lose some weight and then they'd restore it, maybe add a little bit extra, and then they'd be slightly higher when they started again, and then add a bit extra, and so on and so forth. And this cycle continues through their late 30s, into their early 40s. Lose weight, improve your numbers, regain weight, worsen numbers, lose weight, improve your numbers, regain weight, worsen numbers, and each attempt became harder and harder. And at the same time, their knee, which had been occasionally achy, sometimes when the weather was bad, since the motorcycle accident in their youth, all of a sudden it starts protesting a little bit. More frequently, not all the time, just, once in a while, and more and more frequently as time went on. Exercise becomes more challenging. And every time they'd see a new doctor for whatever reason, or went in for a routine physical, the doctor would look at the pattern. Oh, look at you weight cycling, and look at your blood pressure and your blood cholesterol going up and down, and just assumed that Jay was lazy and irresponsible and simply wasn't trying hard enough. So I just want to stop there to point out that weight cycling is a risk factor for high blood pressure and high cholesterol. That's what I'm going to say. We'll talk about it a bit more later. But weight cycling is a risk factor for high blood pressure and high cholesterol. So the doctor assumes they're lazy, but don't get ahead of yourself, Asha. Now we come to the present day. Jay is now 45 years old, caught in a frustrating loop. You're familiar with it, listeners. I'm sure you are. Many of you have been there. They've got blood pressure medication. That's been increased a couple of times already. They're now on more than one medication. Their cholesterol levels are up and down. They're constantly being threatened with statins. The knee pain limits their activity, which makes it hard for them to exercise. And they've been told that the only way to lose some weight is to eat less and exercise more. Except for nowadays, they're being told to maybe consider medication, maybe even consider surgery. Every single doctor's visit feels like a judgment. Every health concern they have is constantly blame on their weight. Doesn't matter what the actual issue is. It's just straight around, not really taken very seriously. Lose some weight, lose some weight, lose some weight. Most recently, they've been seeing their doctor about their worsening knee pain. And when they first mentioned it, doctor barely even glanced up, didn't even look up from their notes, just said, yeah, well, at your weight, pain's to be expected. Of course, that's what it is. It's just your weight. No examination. Didn't ask any more questions, really. Didn't even mention the injury, probably didn't even know, didn't look through their notes, didn't discuss anything about weight cycling and how that might have impacted their knee. None of that. Just, oh yeah, your weight, obviously. Obviously. And that was the end of that. So this is also, again, I'm going to say, I'm going to put it out there, it's very, very common. We go to see our doctor about, oftentimes it's a knee or an ankle or a hip or a joint or a rash or whatever it might be. And the doctor just goes, yeah, that's your weight. Doesn't even look up from there, oh yeah, that's your weight. Doesn't even examine it. How could you possibly know without examining it what could be causing the knee pain? But whatever. This is very, very common, right? And studies have shown that doctors, because of their weight stigma, because doctors have such negative beliefs, attitudes, assumptions, stereotypes of fat people, will often forego the examination, forego the investigations, much less likely to examine their fat patients than they are their thin patients. And we've got studies that support this. So, yeah, it's a bit problematic, isn't it? Um, as I said, the doctor just says, lose some weight and I'll refer you to physical therapy. That's your classic kind of response to knee pain, someone else's problem. Lose some weight, go see a physical therapist. And to be fair, physical therapists are really good at managing knee pain and joint pain. I don't have a problem with that. But Jay's first physical therapy appointment was a very rushed 30-minute session. Therapist didn't spend that much time looking at their knee, focused on their computer, asked a lot of questions, spent a lot of time talking about weight loss, prescribed exercises that kind of felt like they were sort of from a template, a standard, like, here's knee pain, let me just tell you what you need to do. Very standard, not really making any effort to decide whether or not they were suitable for Jay. So, the usual wall sits, leg raises, step ups, things like that. And then Jay says, well, hang on, step ups actually cause really sharp pain every time I do it. And the therapist says, well, maybe just don't do so many of those and try the other ones instead. Here's your leaflet, off you go, goodbye. Not great. And since then, Jay's been doing these exercises because that's what the physical therapist said. But that routine has been making things worse. The pain is getting worse every time they do it. It's getting worse and worse. They're trying to do their straight leg raises, and that's causing a bit of like a grinding sensation. And when they do their wall sits, their knee feels like it's about to collapse, like it's about to give way. And so after a couple of weeks of this, they're like, "Oh no, this is not for me. I can't keep doing this. It's getting worse." So they stop the exercises. Understandably, they avoid them and they avoid the physical therapist because, as far as they're concerned, physical therapist said, "Do this." They couldn't do it. That's another fail. That's another, something to get told off about. So they missed their next appointment, understandably so. What frustrates Jay the most at this stage is that, like, their doctor dismissed their concerns, right? Didn't even watch them walk, didn't examine their knee, didn't examine the range of motion or feel for any tenderness or anything like that. During their last appointment, when Jay was trying to explain that they can no longer kneel down, and they've been trying to do some gardening because that's something they really like doing, and walking the dog, which is something that they try to do every day. And when they said, I can't do that anymore, the doctor was just like, oh yeah, well, you know what you need to do. You need to lose some weight. You need to exercise, do what your physical therapist says. There was just no attention paid whatsoever. And folks, for those who are new to the podcast, we call this medical weight stigma. What is weight stigma? Well, stigma is the very real sort of consequences of these very negative beliefs and attitudes and assumptions that people make about higher weight individuals, about fat people, because it's not just that people are looking down on us, or medical professionals are looking down at their fat patients. That's one thing, judging them and have all these stereotypes in their mind. That's problematic in and of itself. Medical weight stigma is the real life consequences. It's the doctor that isn't paying attention, isn't looking for red flags, isn't concerned, is blaming everything on weight, is missing the diagnosis, is failing to treat when they should be treating. It's the doctor who refuses to examine or investigate when they should be, when they would be, were it a thin patient. That is medical weight stigma. That is really problematic. And when we think about Jay and Jay's life, their world is shrinking. They've given up on, gardening because it's too painful. Their dog walks are slower. And their dog, even their relationship with their dog is suffering, like it's just not as fun as it used to be. Grocery shopping is drama. just going around and moving around. They plan their trips around which stores have like, motorized carts and what, what ones that they can hang on to. And, they're starting to have to use mobility aids and stuff. And that's really embarrassing for them. And hey, I know it's a bit of internalized ableism there. We all have internalized ableism, but it's embarrassing. They're like, I'm 45 years old. I shouldn't need to use a cane or a stick or a motorized cart. Like that is not okay. And the simple tasks in life become complicated, right? They're basically having to negotiate with their pain, with their range of mobility. Um, Sometimes, they need a shower chair, a shower chair. They need to be very careful about how they get in and out of Betsy because Betsy's quite low, the door's quite low down, so they have to do like this whole like ease out sideways, then hold on to the door frame, then hang on for a second, then slowly drag their leg out. You can't just get in and out of Betsy willy-nilly anymore, which is a problem because as we know, Betsy has a tendency to not break down, just, be a bit temperamental from time to time. And so that's really problematic. They going up the stairs, things like that, really difficult. And yeah, they're supposed to go, do some swimming, they're told. All right. The reality is that the nearest gym and, swimming pool is over half an hour away by car. Um, their neighbor Sarah's like, oh, you know what? You should try my chiropractor. My chiropractor's amazing. Will totally change your life. And Jay's thinking, okay, I've got all these medical bills. I've got all these problems. I'm not able to work as much. My income is decreasing. It gets really, really difficult, and it becomes more and more challenging. The sort of the smaller your world becomes. So if you can't travel to work and you're working from home, then you miss a lot of the socializing, right? And if you can't get in and out of a car or into a bus or you can't get up and down flights of stairs, your life gets so much smaller and it becomes so much harder and more challenging to do the things that you really like to do. Oh yeah, it'd be great if I could go to the gym or go to the pool, but that requires me to have access to a pool. And it requires me now to have access to a pool where I feel safe getting in and out of it. And that's not that easy. It's certainly not easy for Jay. Um, and understandably so, Jay is starting to feel hopeless. Their mood is deteriorating. They're feeling depressed. They're tired of their body being treated as a problem to be solved rather than a very complex system with a 2-decade history of medical interventions and attempts at improvement. They want a healthcare provider who will see them as a whole person, not just a number on a scale or a set of lab results, but a whole person. They are ashamed. They are understandably ashamed. They feel guilty. They feel like it's all their fault. Why? Because these are the messages that they're receiving all the time. This is what their healthcare practitioners are telling them. It's your fault. And that is, so this self-blame, this guilt, this shame, this is reinforced by every single one of their medical encounters. Now, sounds terrible, but this is the whole point of the podcast now. I want you to imagine that Jay goes to visit the doctor, bracing themselves for another weight loss lecture, and instead encounters a doctor who goes, oh, let's examine your knee, shall we? First things first, take a walk across the room, checks their gait, examines their knee, feels for points of tenderness, checks the range of motion, listens to their history. Wait, you had a motorcycle accident 20 years ago. Oh, I see. Tell me about that. Tell me about your knee pain since then. It's like, oh my gosh, this doctor actually cares about me. This doctor doesn't just want to get rid of me. And so imagine a doctor that says, you know what, this all makes a lot of sense with your old injury combined with years of inadequate treatment, missing the important bits that, as you may know, major injuries, trauma and injury at a young age predisposes you to arthritis in the same joint at an early age. So early onset arthritis is very common after a severe injury. So this doctor's immediately thinking, well, is this early onset arthritis? Especially if instead of treating it when we should have been, we've been offering, we've been suggesting all sorts of things like weight cycling, which, by the way, weight cycling makes it worse. So the doctor's like, yes, okay, this all makes sense to me. I totally understand. And first things first, we need to order an x-ray. We need to see what's going on in your knee. We also have to have a conversation about chronic pain and how it's impacting you, how it might be impacting your blood pressure and your cholesterol and all of these things. And when Jay brings up their history of weight cycling, and says, "Oh, it's probably all because of my weight," the doctor says, "No, no, well, it's got nothing to do with your weight. In fact, it's the fact that we've been focusing on your weight rather than your well-being that's caused so many of these problems in the first place." The doctor explains that weight cycling is actually detrimental to health, and that stable weight, whatever that weight is much healthier. The doctor talks about how actually weight cycling can impact your blood pressure, can impact your cholesterol levels, can impact your inflammation levels, can even impact your perception of pain. And so they say, we're not going to be talking about your weight from now onwards. Okay. And they also take a moment to acknowledge the pain that Jay has endured at the hands of other medical professionals. Now, I want you to imagine that the conversation about exercise shifts dramatically. The doctor says, you're not pushing through pain. If you're in pain, that's your body's way of saying, stop what you're doing. So instead, the doctor says, you've got to listen to your body. Forcing painful movements actually is going to worsen your condition. So it's important to find comfortable ways to move your knee and to strengthen the muscles that support the knee joint. We need to go back to your physical therapist. We need to start talking about how to manage it. But without, and we don't even have an x-ray yet. So we need to first find out what's going on. And then, in terms of their medication, the doctor spends an adequate amount of time sorting out their analgesia so that Jay is no longer in chronic pain and that their life can stop shrinking and start growing again. The doctor takes some time to talk about their blood pressure medication and just says, look, lots of people are on blood pressure medication. It's not a moral failing. You haven't done anything wrong. It's just, if you think about it, it's a good thing. We're trying to reduce your risk of health problems down the line. So it's like wearing glasses. It's not a failing that you need to wear glasses. If you can't see properly, you wear glasses. And if your blood pressure is a bit high, you take medication. That's the end of that. The doctor talks about how important it is to stop weight cycling and to try and reduce stress in a manageable way. And one of the important things is stop stressing about your health and acknowledging that the stress surrounding Jay's health all stems from the medical advice they've got for the last 10, 15 years. In fact, it all started with that doctor's appointment when the doctor said, oh, your blood pressure is 145/95, you need to lose weight. Actually, the correct management of that blood pressure of 145/95 would have been to order either some home blood pressure monitoring or some ambulatory blood pressure monitoring, deciding whether it is actually abnormal and then starting treatment straight away. What the doctor did was completely negligent. So, there needs to be some mention of the past trauma they've experienced at the hands of doctors. I want you to imagine that encounter. I want you to imagine the turning point for Jay in that moment when they begin to realize that their health journey isn't about fighting their body, fighting their weight, fighting their blood pressure, fighting their cholesterol, fighting their knee pain. When they begin to realize that actually it's about working with what is going on and treating their body with kindness. Folks, that's what weight inclusive management looks like. It looks like a proper physical examination. It looks like appropriate imaging, in this case, an x-ray. It's an acknowledgement of weight cycling's harmful effects. It's an acknowledgement of medical trauma and how that has impacted your health journey. There's a focus on pain management and management of, function. So if you're tired, it's about managing the tiredness. If you're in pain, it's about managing the pain. There's a destigmatization of medication use as well. That really needs to happen. There's nothing wrong with taking medication if that's what you need to do. There's also a recognition of the challenges, the individual challenges that people are facing. In this case, Jay lives, in quite a rural area, 30 minutes by car to the nearest gym. That means that they're living in quite a rural area, right? So that's going to impact them. Not having enough money to, buy a new car, that's going to impact them. All these things, it's a recognition of how these challenges are going to impact their health and their health care. It's taking the focus off weight. In fact, it's taking weight out of the equation altogether and focusing on things that make a person feel better, working with the person, kindness and that sort of thing, empathy, and compassion and validation. That's what weight inclusive management looks like. And I'm going to go out on a limb here, and I'm going to keep saying it over and over again. Weight inclusive healthcare is the best form of healthcare. In fact, it should be the only form of healthcare. As I've been telling you over and over again, weight loss is not sustainable. Weight loss has not been shown to have any long-term health benefits whatsoever, ever. Weight loss is harmful. Pursuing weight loss is harmful. I should say pursuing. Let me say that again. Pursuing weight loss is unsustainable. Pursuing weight loss has not been shown to have any health benefits. Pursuing weight loss causes harm. Also, weight stigma, which is a natural consequence of weight-centric medicine, which is the opposite of weight-inclusive medicine. Well, weight stigma is harmful in of itself. Weight stigma is a risk factor for poor health outcomes. Weight stigma causes lots of harm. Also, weight cycling is a risk factor for poor health outcomes. It also has a lot of dangers associated with it. And since pursuing weight loss is unsustainable for the vast majority of people, then every time you go on a diet, you are essentially embarking on the first stage of weight cycling. The second stage of weight cycling is when you begin to restore your weight. So what I'm trying to say here is that there is never any benefit to prescribing weight loss. Never, ever, which is why weight inclusive management is, as far as I'm concerned, the only form of medical management out there. So I hope you found that helpful. I hope you enjoyed Jay's story. Jay's story is part of a blog post that will be linked to the show notes. I'm pointing like that. If you're on YouTube, the show notes are down below in the comments. Remember that you can also, whilst we're here in the comments, if you've got a question that you want me to ask and ask me anything, I will do my best to answer it. Now, before we get to ask me anything, I wanted to focus on. That's not the word either. I want. Let's just do everything you've been told about weight loss is a lie, shall we? Everything you've been told about weight loss is a lie. Today, coming to you with this article, The Role of Diet and Exercise and of Glucosamine Sulfate in the Prevention of Knee Osteoarthritis. Further results from the Prevention of Knee Osteoarthritis in Overweight Females study, or PROOF for short. Yeah, proof. The proof study was basically evaluated the effects of a diet and exercise program and glucosamine sulfate, which is it's a supplement on preventing osteoarthritis of the knee in women aged between 50 and 60 years. I say women or females. There is absolutely no mention of trans people, of people who were not born female, but that's by the by. That's always the case. So we can assume this is just talking about cis women. So the proof study, how many did I say? It was 407 participants. It was a 2.5-year trial. It was 407 participants, 3 groups, diet and exercise program, glucosamine sulfate, and controls. Followed for 2.5 years, and they measured arthritis of the knee using X-rays and measuring the space between the joint, or looking for joint space narrowing. That's how they did it. All right, and so this was a pretty decent study, probably one of the best studies we have out there about preventing arthritis of the knee. As you can see, it's a randomized trial, so I would argue that it's pretty decent. 407 participants, not bad. All studies have their limitations, but I think this is, as far as they come, pretty good one. So what did they find? First of all, the diet and exercise program did not reduce the risk of osteoarthritis of the knee. I say that again. The diet and exercise program alone did not reduce the risk of osteoarthritis of the knee. Glucosamine sulfate actually did. By about 59%, actually. So that's not bad. I'm not going to say, based on this evidence, that taking glucosamine will definitely reduce your risk of arthritis. However, based on this evidence, it's possible, it's a limited study, but it's possible that glucosamine may prevent osteoarthritis of the knee. I don't think there's any evidence that it treats it, but I think there might be some evidence about it preventing it. Just putting it out there. But the diet and exercise did nothing. And do you know what this, because it's always the case, do you know what the authors concluded? Because I think it's really, I always enjoy when people go out, sort of set out to prove that diet and exercise reduces your risk of osteoarthritis, and then it turns out it doesn't. So then they have to come up with a reason, of course. The reason was, well, it was likely due to insufficient weight loss. It just didn't lose enough weight. If you lost enough weight, it would have been fine. Well, first of all, that's not true because there's never been any studies to show otherwise. It's not like people who lost more weight were less, there was absolutely no link whatsoever. Because you could just argue, well, all right, let's look at the 10% that lost the most amount of weight. Did that prevent arthritis? No. So I don't think that it's about the amount of weight loss. But even if it is, even if that's the case, well, they went on a diet and exercise program, right? And well, we know weight loss is unsustainable. We know that weight loss is very hard to achieve. People are always like, lose 10% of your weight. Well, actually, on average, when people go on a diet and exercise program, the average amount of weight loss is more like 2.5%. So, whether or not it's not good enough, it doesn't matter. The fact is, going on a diet and exercise program will not reduce your risk of osteoarthritis of the knee. You're welcome. According to this study, I should say. You're welcome. I hope you find that fun. I've got an Ask Me Anything question. It was very good. There was a pun, and I love a pun. Can you weigh in on how to manage cholesterol without weight loss? High cholesterol, sorry. Oh, I didn't say it right. It was very good. Can you weigh in on how to manage? I see your pun, and I enjoyed it. Thank you for that. Um, right, little brief bit of science here before we begin. So when you have your lipids measured, they measure two things. One is your triglycerides, and then the other thing are the lipoproteins. So the LDLs, the low density lipoproteins, that's your what we call bad cholesterol. They do measure your total cholesterol, but nowadays we're more interested in the bad cholesterol, which is the low density lipoproteins. The good cholesterol, we want that to be high, the HDLs. I'm not talking about those today, I'm talking about LDLs. Now, let me tell you what the difference is between these two lipids. Triglycerides are your body's primary energy source, right? And that's what's stored in the fat cells, triglycerides. Cholesterol is actually it's a somewhat waxy substance that is used to build the membranes of the cells. It's used to produce hormones. It's used in digestions. It's got lots of uses, but it's not actually an energy source. The triglycerides are the energy source. The cholesterol is actually used for lots of other functions. Now, the reason we measure it is very simple. LDLs, low density lipoproteins or bad cholesterol, transport fat through the bloodstream. So basically, what happens is your liver takes your let me try and get this right. So your liver takes the triglycerides and adds the cholesterol and releases it into the bloodstream. And we call this a VLDL, or a very low density lipoprotein. Then, once the triglycerides are lost and they go into the cells, on the fat cells, what's left is the LDL, and that's what we measure, right? So the liver turns energy into fat, mixes cholesterol with the triglycerides. They join together to form a VLDL. They get released into the blood. Then the triglyceride portion, which is the energy, gets magically melts. It doesn't. There's a whole big process, but I'm not going to go into that. So once it's lost the triglyceride portion, it's just the LDL now, and it's floating through the bloodstream. And that's what we like to measure. And you see, what we know is that LDL can lead to plaques, fatty plaques, building up inside our arteries. And as they slowly build up, they narrow the circumference of the artery, so there's less space for the blood to flow through. And eventually, if they completely block the artery, then you won't have any blood going through whatsoever. And so the area of the body that artery supplies can die. So if it's the if it's the artery supplying the heart and they narrow up, it can cause a heart attack. If it's the blood vessels leading to the brain and they narrow, it can cause a stroke. And if it's the ones that supply the limbs, say, and they narrow, it can lead to ischemia and then eventually to amputation. So we call this cardiovascular disease, right? The fatty buildup of plaques inside the arteries that cause cardiovascular events, whether it be a heart attack or a stroke or an amputation or anything like that. This is cardiovascular disease. So high cholesterol is a risk factor for cardiovascular disease. So when we talk about cholesterol, oh, you've got high cholesterol, low cholesterol, good cholesterol, bad cholesterol, and all that stuff. There isn't an exact number, right? There isn't like a universal number. This is good, this isn't good. And we say 5, we say 6, depends on who you listen to, it depends on the units that you use. But actually, when we're measuring cholesterol, we need to be working out your individual risk. And that's the key to managing cholesterol. So when we work out your individual risk, in the UK, we use something called a Q-risk score. But in other parts of the world, there are other risk calculators. I'll try and link them all in the show notes so that if you can use your own risk calculator to decide what your risk is. And this is really important because if you're at a low risk, the key to managing your cholesterol is do nothing. Literally do nothing because there isn't anything you can do to really bring it down. There's no studies that have shown that any interventions whatsoever bring it down. Possibly the plant sterols that you can get, like there are drinks like Benecol, and various kind of like cholesterol lowering supplements and stuff that you can buy in like in food stores, in grocery stores, in health food shops. Possibly they have some impact, so you can try those. But other than that, there is no evidence that any interventions with sort of with low risk patients is of any benefit. If you've had a cardiovascular event, you have to be on that's what we call now secondary prevention. You've already had a cardiovascular event, then we absolutely have to treat you. If you're somewhere in the middle, so your risk is high, it's higher, it's not low, it's moderate or it's high, but you haven't had a cardiovascular event, you're the people that we really want to do something about because you haven't had a cardiovascular event. So we're trying to prevent the first one, and we call this primary prevention, preventative medicine. So you're the ones that I'm talking to right now. What should you actually do? Well, here's what you shouldn't do. You shouldn't try losing weight for two reasons. Number one, going on a diet increases your cholesterol levels, especially low carb diets. It increases your LDLs. It causes higher lipids. So definitely don't try and lose weight. Weight cycling makes it even worse. Weight stigma also makes it worse. So please, please do not attempt weight loss. That's the last thing that you want to do. There are very few interventions, as I said, that you can do in life to prevent this process from happening. Really, what you want to do is you want to consider starting a statin. Now, whether you start a statin is up to you. There are pros and cons. You should discuss this with your own physician. The only thing that I will say is that statins have been shown to reduce your risk of cardiovascular disease by 25%. If your risk is 4%, and we reduce it by 25%, we've reduced it from 4% to 3%, which I'm sure you can agree is not really worth it. If your risk is 20% and we reduce it by a quarter, we've dropped it to 15%. Now that's not bad. If your risk is 40% and we start you on a statin, that reduces your risk to 30%. That's pretty impressive, right? So it very much depends on your individual risk. Now, I will say, and this is always the case whenever I do and ask me anything, I am not your physician. I am not telling you what you should or shouldn't do. All the advice I give in my podcast, in my Instagram, in anything, is not me acting as your doctor. It is me telling you what I know, sharing information. You should discuss this with your own physician always. When you go and see your physician, what I suggest you ask is, what is my individual risk factor? What are the pros and cons of starting a statin? And it's also worth saying, look, I know that weight loss interventions are not an option for me. I therefore do not wish to discuss them, and any attempt to discuss them with me only serves to further stigmatize me, which is going to make it worse rather than better. So you can absolutely speak to your physician without having the weight loss conversation. If you want to know more information, head to my website. There are lots of resources on there. There is a script that you can take with you to the doctor. You just need to download the free script, and then you can just write down, you can customize it for your personal doctor's appointment and take it with you and just read from it. So that's quite useful. Don't forget that my book that I'm writing is called No Way. I have a course that goes alongside the book writing process. I also have masterclasses which you can watch on demand. There isn't one about cholesterol. There is one about fatty liver disease. There is one about arthritis of the knee. There is one about high blood pressure. So if you're listening and you're like, oh, I'd like to know more information, please, Asha, head to my website. The link will be in the show notes and in the comments below, and then you can check out the masterclasses as well. Thank you very much, ladies and gentlemen, boys and girls. In fact, I shouldn't say that. I'm used to saying that, but I don't know why I say that because that's very gendered. Thank you very much, everybody, for being here. Next week, I have a guest. I'm just going to leave it at that. I have a guest. You'll have to show up next week to find out. I'm actually not telling you because we haven't recorded it yet, and just in case things don't work out. But yeah, next week, hopefully, I'll have a guest. See you then.